Thank you so much, Sunil. Just to confirm that you're able to hear and to see my screen.
Yeah.
Perfect. So I must say, after your introduction and Professor Badada's talk, I'm not sure whether I'm going to be able to teach the endocrinologists anything more about hyperpara. But just thinking about the complications of hyperparathyroidism, I'm not sure whether you were aware that with the exception of 3 of the lightest elements, and that's helium and lithium and nitrogen, all the chemical elements in the universe apparently originated from the nuclear reactions in stars that made the stars shine. So calcium and phosphate, which is the problem in primary hyperpara, is just something we can blame maybe on our stars. But also just to note, that calcium is the 5th most abundant element in the Earth's crust, and that I'm going to show you that slide now, and that the Pieta, or a lot of statues that's actually marble or limestone, is a majority of calcium, similar to the human skeleton. So I also thought that I'd just show you where I work, and this is Tygerberg Hospital during the peak of the COVID pandemic, and these pictures were actually taken by one of our fellows. And you can appreciate the most beautiful sky and then the autumn leaves from dusk to dawn. So on that high note, thank you, Dr. Badada, for also sharing Imran Farouk's work. This is some of the Tygerberg data from our primary hyperpara work. And very similar to what you've alluded to, is the majority of our patients, as you can see, are females, mostly elderly. The majority, despite having a significant degree of hypercalcemia, are in fact asymptomatic. Having said that, most of them, I think more than 70 or 80%, actually have more than 2 indications for surgery at the time of presentation, suggesting a quite late presentation. And also then very similar to what you see in India, the degree of vitamin D deficiency. So you can appreciate that 80% of our patients have a significant vitamin D deficiency. 1 out of 5 of the patients in this registry had evident vertebral fractures at the time of diagnosis. And as you can appreciate, the degree of hypercalcemia is quite significant, with 1 out of every 4 patients having a calcium that exceeds 3 millimoles per liter. Again, the PTH, and I really enjoyed the case that you presented with a low normal PTH, but certainly that is the exception. So also 1 or 2 of our patients had PTH that was in the low normal range. Only roughly 5% PTHs within the normal range, and then the majority of our individuals' PTHs that exceeds the upper limit of normal 2 to 3 times. Interestingly, not very high urine calcium levels, but the confounder obviously is the significant degree of vitamin D deficiency. So the case I'm going to share with you today is a case we saw a year back, and it would be great to collaborate in terms of, or just discuss the management of this patient from your experience with hungry bone disease in India. So Mrs. M.M. was a 56-year-old lady that apparently for many years had this lesion in the jaw, in the left jaw. And the fact that it increased in size brought her to the medical attention, or motivated her to seek medical care. And before she presented to the maxillofacial surgeons, she noted that there was an increased growth. So she was known with hypertension, increased cholesterol, and was told us that she has a heart problem. I'll elaborate on that a little bit later. The anthropometry and the vitals were essentially normal, and the only medication relevant, I suppose, is a very low dose of hydrochlorothiazide that we didn't think played a significant role in the hypercalcemia, or causative role in hypercalcemia, just due to the degree of hypercalcemia and the very low dose of thiazide diuretic. That's a little bit of a close-up. So the photo on the left-hand side, you can appreciate this intraoral lesion with a significant increase in size after 6 weeks while awaiting a biopsy. The other relevant findings on clinical examination was this bony protruding lesion on the right anterior tibial area, and a clinical examination that was in keeping with mixed aortic valve disease that turned out to be also a very rare entity, which was a unicuspid aortic valve on echocardiography. Obviously, we didn't pick up the fact that it was a unicuspid aortic valve clinically. We just thought it was a mixed aortic valve disease. So this is the CT scan of the maxilla, and you can appreciate this very large mass lesion that sort of displaces the surrounding bone with very limited calcium inside the lesion visible. This is the mandibular lesion on the left side that I've showed you with the intraoral inspection, and this is just to appreciate it on the CT. So initially, the maxillofacial surgeons were concerned about a possible malignancy. And as a result of that, they actually asked for a CT chest. And it's quite interesting, if you zoom into the CT chest, you can appreciate this sort of lucid area in the anterior sternum without much of other anatomical abnormalities in this cut of the CT scan. So they proceeded to do a biopsy of the maxillary lesion, and it turned out to sort of be consistent with a giant cell lesion with an impression of a peripheral giant cell granuloma. So in summary, a 56-year-old patient with a unicuspid aortic valve and a consequence of mixed aortic vessel disease, a maxillary lesion of giant cell origin, and a significant degree of hypercalcemia. If you're not familiar with our international units, you can just refer to the reference range in that column. So if we just have a look at the biochemistry, you can see the significant degree of hypercalcemia. Phosphate appropriately decreased with a normal renal function. And I think subsequently, the family physician that saw these results referred it to endocrinology for a workup for hyperpara based on the phosphate level. And I always, am humbled by the biochemistry in terms of localizing pathology. And clearly this does not fit in with the malignancy, but with primary hyperparathyroidism, with a significantly elevated PTH, an alkaline phosphatase that is increased 6-fold, and again, this significant vitamin D insufficiency as that we've discussed. We'll go on to have to review the rest of the biochemistry and the evolution of it a bit later in the presentation. So certainly a biochemical diagnosis of primary hyperpara. So the differential diagnosis at this stage is that of hyperparathyroid jaw tumor syndrome, or possibly hyperparathyroidism complicated by Brown's tumors, and then obviously something unrelated, so two conditions that co-occurs. So what do endocrinologists do best? They define the etiology of the disease and they quantify the end organ involvement, as we've seen so elegantly in the previous presentation. So we know that the skeletal effects of PTH is quite dichotomous, with the anabolic and the catabolic sort of consequences of that. And I mean, as the previous speakers also alluded to, that in the presence of primary hyperparathyroidism, the catabolic features that persist and that has the most deleterious consequences on the skeleton. So the classic rugged jersey spine that we see on the left-hand side, and this is the lateral X-ray in our patient. So if you use your imagination, you can appreciate that at the vertebral end plates, there is some sclerosis, and this is usually due to the PTH effect on the osteoblasts on these surfaces, as opposed to the increased osteoclast activity more towards the center of the vertebrae. Bone mineral density, as expected, significantly decreased. You can appreciate the T-score there in the yellow box towards the left-hand side. a predominantly affected cortical bone area, as we would expect in secondary hyperparathyroidism, or in primary hyperparathyroidism as a secondary cause of osteoporosis. And then the Z-score always useful to me to sort of indicate that there might be a secondary cause of osteoporosis. On the lateral chest X-ray, you can clearly appreciate vertebral fracture. So over and above the low bone mineral density diagnosis of osteoporosis, also a prevalent fracture. And apologies, but I didn't include the distal radius in this specific slide. Maybe just sort of draw your attention to the lateral edges of the clavicles, but other than an impression of subperiosteal resorption indicative of osteitis fibrosa cystica, nothing really grossly abnormal that screams malignancy in her case, other than maybe a bit of an eventration of the diaphragm. So we've sort of touched on osteitis fibrosa cystica, that is due to the resorptive effects of PTH on bone. And this is the radiological equivalent of the clinical manifestation, which is usually bone pain. And it sort of represents a significant degree of subperiosteal bone resorption, but is often misdiagnosed, as was suspected in this case, as a metastatic carcinoma, which has significant impacts on the patient's outcome. So just to sort of zoom in a little bit on the X-rays of the shoulders, there's the distal clavicle that I've just showed you in the previous chest X-ray, but you can clearly appreciate these loosened areas in the proximal aspects of the left humerus and a little bit of bone expansion distally, and similarly, in the right proximal humeral head, extending a little bit more distally, these loosened areas. This is an X-ray of the patient's skull. Again, this lucency in the skull, but clearly not the classic salt and pepper appearance that we see with osteitis fibrosa cystica. So we proceeded to sort of quantify the skeletal involvement with functional imaging and nuclear imaging, and also utilized the services to localize the hyperfunctioning parathyroid tissue. So in the middle, you can appreciate this is the anterior pectinate scan that clearly nicely outlines the thyroid. We know pectinate only taken up in thyroid tissue, and you can appreciate an area of increased uptake that sort of suggests a thyroid adenoma. Following onto the MIBI uptake, you can see that despite the thyroid uptake, there's a significant increased uptake towards the right side of the to the left side of the thyroid. Sorry, this is all in inverted images. And then on the subtraction images, a clear picture in keeping with a right inferior medial parathyroid adenoma. Again, on SPECT imaging, so in terms of SPECT, we don't routinely do SPECT imaging when we do parathyroid MIBIs. We usually reserve it for parathyroid tissue that's more difficult to localize. So, if it's less than 1 centimeter and so forth, obviously you don't know that up front. But we've got standardized protocols, and often these slip through where the patients get both MIBIs and SPECT scanning for localization. But once again, clear uptake in the inferior medial area. In order to better quantify the skeletal involvement, we proceeded with bone scintigraphy. And just to draw your attention to the areas we've previously radiologically looked at, you can see the increased uptake in both the proximal humeral heads, the pelvis, various areas in the pelvis. The lesion on the tibia is corresponded clinically to the lesion that we saw protruding on the leg. Again, the femur, and then significant uptake in the sternum that was compatible with the lesion we saw on the CT scan, and then at the costochondral junctions with various other, that was just the injection site, with various other areas of increased uptake. So the story evolves: a 56-year-old patient with hypercalcemia as result of primary hyperpara with a right inferior parathyroid adenoma, a unicuspid aortic valve that hasn't given us problems up to now, with a giant cell lesion in the maxilla and in the mandible, and multiple osteoblastic skeletal lesions. So the moment you think of atypical presentations of parathyroid disease, I think it is good practice to consider hereditary states of hyperparathyroidism. In her case, specifically the hyperparathyroid jaw tumor syndrome, because of the jaw involvement. And I think the reason for considering this was because of the concomitant or the company it keeps. You know, these individuals often have uterine and renal involvement, so growths in other areas. Obviously, MEN, which was really not as high up in our differential diagnosis in terms of her, and the degree of hypercalcemia with the degree of hyperpara and the localizable parathyroid adenoma really excluded FHH. So, a few words on hyperparathyroid syndrome. So these are usually fibroosseous tumors that can either coexist with or without the parathyroid adenomas. It usually occurs, or it usually should be suspected in younger individuals, similar to the MEN syndromes, who present with primary hyperpara and growths in the jaw. The parathyroid adenomas in hyperparathyroid jaw tumor syndrome can often, even though it is mostly single adenomas at presentation, they can often reoccur after surgery. And the lesions, the fibroosseous tumors, only occurs in the jaw. It doesn't occur anywhere else in the body. The reason or the pathophysiology that the adenomas is due to an insufficient suppression of a tumor or a mutation that results in an ineffective germline tumor suppression effect and via cyclin D1. So these ossifying fibromas in hyperparathyroid jaw tumor syndrome are usually in themselves benign. The only consequences is the anatomical consequences and the displacement of the surrounding tissues that leads to pathology or to being unwell in a patient. As I've mentioned, it only affects the maxillofacial area. So the fact that our patient had a lesion on the anterior tibia actually argues against hyperparathyroid jaw tumor syndrome. It is usually an area that is bone replacement of fibrous cellular tissue, but the foci and the mineralization is very heterogeneous. So it can range from being very calcified inside to not being calcified at all. And the molecular mechanisms is of most part really unknown. But importantly, imaging cannot adequately distinguish from an ossifying fibroma or between that and a Brown's tumor. And you will appreciate that these ossifying fibromas look very similar on the CT scan that was apparent in our patient. So primary hyperparathyroidism with concomitant Brown's tumors accounts for less than 2% of primary hyperparathyroidism and really represents quite advanced stages of the disease. It's usually non-neoplastic and can affect any part of the skeleton, but common areas are the ribs, the clavicles, and the pelvis, as we've seen in our patients. Mandibular involvement has also been noted in primary hyperparathyroid with jaw tumors, but in a significant low percentage. So only roughly 5 out of 100 patients with Brown tumors will have mandibular or maxillary involvement. So these Brown tumors are called Brown because of the hemosiderin-loaded macrophages, giant cells, and fibroblasts that fill the cystic spaces as a result of increased osteoclast activity and subsequent vascularization. And the way in which to address the Brown's tumors is to treat the underlying cause, the primary hyperparathyroidism. There's been some case reports of brown tumors that increased in size after parathyroidectomy or normalization of primary hyperparathyroidism per se. So we reconsulted our friends, the pathologists, and told them that we clinically suspected rather a Brown's tumor. And they subsequently issued a supplementary report and agreed with us that it's a giant cell lesion that is compatible with a Brown's tumor of primary hyperparathyroidism. So while we were awaiting surgery for her, we administered zoledronic acid, 5 milligrams. So the trade name in South Africa is Zumeta, a potent bisphosphonate, with a subsequent drop in phosphate despite vitamin D replacement, and then a significant response in terms of the hypercalcemia that kept her home over the Christmas season. And then in January, when we readmitted her this year for this parathyroid surgery, again, a relapse in terms of calcium levels, and given 2 days before surgery, a second dose of zoledronic acid. You can appreciate the nice response in alkaline phosphatase after the first zoledronic acid was administered, and also an expected increase in PTH, as you expect when you administer bisphosphonates. So the pre-op optimization included vitamin D replacement with cholecalciferol. The week before surgery, despite having hypercalcemia, we actually also elected to give her 1-alpha vitamin D and concomitantly then the zoledronic acid also to manage the hypercalcemia. Intraoperatively, our endocrine surgeon didn't have any trouble to localize this parathyroid adenoma, and you can appreciate this towards the parathyroid adenoma, also a right thyroid lobectomy that was performed as a result of the previous image that indicated a parathyroid or thyroid adenoma. So I'm so happy that I'm in the company of people that are very familiar with hungry bone. This is just to show you her biochemistry following her surgery. So the 6th of January, she had her surgery. Calcium level dropped overnight from 3.2 to 2.34. And then by around the 10th, so day 4, day 5, a significant drop in calcium levels, despite us being quite proactive and replacing the calcium. So after 24 days of replacing calcium in significant doses, continuing with the vitamin D supplementation and ensuring that she's got adequate magnesium levels, the patient unfortunately deteriorated clinically from an aortic incompetence point of view and developed frank aortic regurgitation. So just a few words on hungry bone syndrome. We know it's due to the influx of calcium into bone when we remove that sudden effect of the high circulating levels of PTH. It is usually prolonged and associated with an increase in alkaline phosphatase and osteocalcin. And the risk factors was clearly evident in this patient due to the fact that she had significant hyperpara, a significant degree of bone disease. In retrospect, the parathyroid gland that was resected also was a predictor of hungry bone. And luckily, she had normal renal function, which is in some series is also a risk factor for hungry bone. So just a few words on the pre-operative measures to prevent hungry bone. The literature is very scant, so there's very little guidance in endocrinology as to what is the most optimal management of these patients before surgery. So in some series, the supplementation of 1-alpha with primary hyperparathyroidism and bone involvement resulted in a significant decreased alkaline phosphatase and a decrease in post-operative calcium requirements in some series. Whereas in other series, there was not a difference in terms of the risk to develop hungry bone. So the question from our surgeons always arises is why active vitamin D in the setting of primary hyperpara, where you've got a lot of PTH around. And I always remind them, very happy that I can still contribute to the clinical discussion because the surgeons are becoming quite good in managing primary hyperpara, is that the calcium in primary hyperpara, irrespective of the vitamin D level, actually directly inhibits renal 1-alpha hydroxylase. And therefore, you are not necessarily able to activate your vitamin D. With regards to bisphosphonates, as was used in our patient preoperatively, the rationale is that it significantly decreases the bone turnover before surgery. But the counter-argument also holds true, and that in some patients, the post-operative hypocalcemia can in fact be exacerbated by reducing the bone resorption without time that allows for that coupled increase in bone formation. So the management of hungry bone, and I'm eager to hear how you manage it in India, is at Tygerberg Hospital. We give adequate calcium supplementation. We ensure that there's adequate doses of vitamin D and magnesium around. We generally see a rapid increase in bone mineral density following parathyroidectomy. And I sort of saw in one of the Indian studies, there was actually an increase of more than 300% in bone mineral density within 1 year after parathyroidectomy, which maybe reflects the degree of skeletal involvement and the severe hyperparathyroidism. Just to note that if you perform bone scintigraphy for whatever the reason might be, is that it can remain abnormal for up to 1 year. So what happened to our patient and the skeletal lesions? So clinically, within 1 week after the surgery, this Brown's tumor almost resolved and normalized in size. Unfortunately, she developed infective endocarditis in the unicuspid aortic valve, which was, again, one of the very rare presentations, a congenital anomaly. And as a result of the infective endocarditis, she had an aortic valve replacement, and unfortunately had valve dehiscence in our cardiothoracic surgery ICU and demised before she could be taken back to surgery. I'm happy to report at the time that the calcium levels was normal. So just a few take-home messages. Hyperparathyroidism is an increasingly common entity. It often the company it keeps is often that of atypical features if you don't know hyperpara, and therefore can often be mistaken for malignancy. And the biochemistry can really assist us to differentiate. So if you have a low phosphate, this really adds value and helps to differentiate between the two. Bone involvement in South Africa, as it is in India, is extremely prevalent, with 1 out of 5 of our patients having prevalent vertebral fractures. And in the words of Bolzikian, which is probably the father of primary hyperpara, the most important aspect of localization seems to be the localization of an expert parathyroid surgeon in the management of primary hyperpara. And with that, I thank you and I greet you. Looking forward to the discussion.